It starts with a sudden mechanical failure in the lower back. The surrounding musculature abruptly locks up in a protective spasm, triggering a localized inflammatory response and severely restricting movement. Clinically, this strict initial window of onset is defined as acute low back pain, provided the symptoms last fewer than 4 weeks. This visualization represents the adult population. According to global data, nearly 85% of these individuals will experience this acute condition during their lifetime. But the system fails to resolve a massive portion of these cases. Roughly 20% of this acute population will not recover within the initial 4 weeks. Instead, they cross the 12-week threshold and transition into a state of chronic pain. This stacked bar chart maps the resulting economic damage. The bottom tier represents direct medical treatment. But the massive upper tier, accounting for up to 75% of the total economic burden, is driven entirely by indirect costs, primarily workforce absenteeism. The widespread clinical reflex of labeling these initial acute cases as nonspecific directly drives this 20% chronification rate. The management of these first 4 weeks determines whether a temporary physical strain resolves or transitions into a permanent, high-cost medical condition. The difficulty in managing the world's most common musculoskeletal condition lies in standardizing diagnostics across vastly different global healthcare systems. To establish a uniform protocol, the World Federation of Neurosurgical Societies Spine Committee convened. They utilized the Delphi method, employing multiple rounds of anonymous voting to build an international, evidence-based consensus. This PRISMA flowchart details their screening methodology. It documents the systematic filtering of dozens of peer-reviewed records from the past decade, ultimately isolating the 97 most rigorous studies on the clinical and radiologic diagnosis of back pain. The resulting guidelines replace entrenched medical heuristics with globally vetted data designed to update how clinicians interact with the lumbar spine. In primary care settings worldwide, between 85 and 90% of acute low back pain patients receive a monolithic diagnostic label, nonspecific. The WFNS consensus explicitly states that applying this generalized label is a clinical error that has impaired effective treatment for decades. The reality is that the vast majority of acute low back pain originates from a distinct, identifiable anatomical pain generator. First, compressive forces physically degrade the intervertebral disc over time. This structural compression creates a distinct locus of inflammation and acute pain. Second, progressive degeneration in the facet joints creates a separate source of localized nociceptive pain. Beyond discs and joints, pain generators can be traced directly to sacroiliac joint pathology or mapped to acute strain in the surrounding myofascial tissue layers. Successful early intervention relies entirely on moving past the nonspecific label and executing precise anatomical differentiation. To understand who is actually experiencing these anatomical failures, we have to examine the global epidemiology. This PRISMA chart isolates the committee's secondary search for prevalence data, capturing the 13 qualifying global studies on epidemiology and etiology published between 2012 and 2022. The gathered data debunks a persistent medical assumption that arduous manual labor in developing nations is the primary driver of acute low back pain. Instead, we find an epidemiological paradox. 1-year prevalence rates are remarkably low in developing nations like Nigeria and India, hovering between 0 and 10%. Yet in high-income developed countries like the United States and Germany, prevalence peaks at nearly 40%. These high-income regions present a cluster of risk factors, including aging populations, highly sedentary lifestyles, and rising obesity rates, all placing continuous mechanical stress on the lumbar spine. Because the specific risk factors for acute back pain are culturally and demographically scattered, standardized clinical management at the point of care is the most critical intervention point. That standardized management must immediately confront the most deeply ingrained yet harmful reflex in modern back pain care, ordering an immediate MRI or CT scan. This flowchart maps out the clinical reality. Radiological imaging is only medically justified for a strict minority, the 10 to 15% presenting with red flag signs, which the WFNS defines as severe neurologic deficits, suspected malignancies, or spinal fractures. But for the vast majority of patients, the 85 to 90% presenting without red flags, ordering routine imaging is actively discouraged. Highly sensitive modern imaging inevitably reveals incidental findings. These are asymptomatic, normal degenerative changes that occur as the spine ages, but have zero correlation with the patient's acute pain episode. Disclosing these normal structural anomalies has a severe psychological impact. It introduces deep anxiety, convincing the patient that their spine is structurally damaged and fragile. This fear triggers immediate avoidance behaviors. The patient stops moving to protect their back. This muscular inactivity physically weakens the lumbar support system, while the psychological fixation locks the patient into a persistent pain loop. In the absence of red flags, an MRI is an iatrogenic tool. It generates the exact fear and immobility that leads to the chronic pain it was ordered to diagnose. Correcting these diagnostic failures by replacing the non-specific label with anatomical precision and withholding unnecessary imaging allows the clinician to apply evidence-based protective interventions. This Prisma chart documents the committee's review of prevention strategies, starting with a pool of nearly 3,000 records and systematically filtering down to the 26 most rigorous studies on preventing chronification. A landmark 2016 meta-analysis stands out among these findings, analyzing 21 randomized controlled trials that encompassed over 30,000 patients. The data shows that structured, targeted exercise is the single most effective intervention, demonstrating moderate to strong evidence for risk reduction. Furthermore, the studies reveal a synergistic multiplier effect. When active exercise is combined with higher patient educational status, meaning the patient understands the mechanical nature of their pain, the likelihood of transitioning to chronic pain plummets. Active physical movement and transparent clinical education are the proven shields against chronification. Passive rest and radiologic scanning are the exact opposite. The obsolete clinical paradigm operates on a predictable sequence, slapping a non-specific label on the patient, immediately ordering an MRI, and prescribing passive rest. The new WFNS algorithm reverses this sequence. The optimized pathway demands isolating the specific pain generator, withholding imaging, and initiating early exercise. The stakes are immense. Outdated practices generate billions in costs and drive workforce absenteeism that destabilizes national economies. Primary care physicians, physical therapists, and spine surgeons operate as the frontline defense against an entirely preventable epidemic of chronic pain. To protect both the patient's spine and the healthcare system's resources, clinicians must execute precise anatomical diagnoses and actively protect the patient's mind from unnecessary radiologic anxiety.